everybody to another live offering of the video education brought to you by the Vestibular Disorders Association. My name is Dr. Kathleen Stross, and I'm joined by my colleague, Dr. Danny Tolman. We're physical therapists specializing in the rehabilitation and treatment of those with dizziness, balance disorders, and vertigo, and we volunteer with VeDA. Today, we're talking about a topic I think that's really going to be interesting. In past segments, we've talked about diagnoses and management of vestibular disorders that come from the inner ear. And in those cases, the inner ear or the vestibular system is the cause of feeling not quite right. But today, we're joined by two doctors in the field of optometry and ophthalmology who will be explaining a set of conditions where your eyes and not your inner ear may be the cause of symptoms. So in celebration of the fact that our vision affects our eyes, I brought today my frog glasses just to show that sometimes even though my inner ear is right, it can be the eyes that have it. So welcome Danny and Dr. Debbie and Dr. Mark.
Thank you.
Welcome, guys. So I'm going to give you a little bit of an introduction to kind of set the stage here. Dr. Debbie Feinberg is an optometrist, and Dr. Mark Rosner is an ophthalmologist emergency physician. They are co-founders and co-directors of the Neurovisual Medicine Institute in Michigan, which trains other optometrists to become neurovisual specialists. Dr. Feinberg has been performing pioneering work with binocular vision dysfunction, or BVD, which is a condition where vision misalignment creates difficulties with the two eyes working together to create a single three-dimensional image, as well as difficulties with the two eyes following that image as it moves. Dr. Mark Rosner is the Director of Education and Research at the Neurovisual Medicine Institute. He has been actively involved in developing the specialty of neurovisual medicine in binocular vision dysfunctions research since 2005. He has led the effort to validate the binocular vision dysfunction questionnaire, which is used to identify patients who will likely have BVD that will benefit from treatment. So welcome, guys. Thank you so much for joining us today.
Thank you so much.
Good to be here.
I'm going to try to move you to this way. Let's see. Oh, click on that. There you go.
Yeah.
No? Danny, help me. How do I switch it? There. No?
You should be able to click and drag your window when you have them in that one setting. Yep.
No, I removed them.
We're still here.
Okay, well,
now click and drag their box over to you. There we go.
Okay. How about that intro, though? I'm making progress every time. I get one thing right, I miss something else. It's flawless. Well, welcome. We're excited about having you here today, as I said. Now, tell us about being ophthalmologist and optometry in working with dizzy patients and people who are off balance with brain fog and so forth. What brings you to our vestibular community?
So, in general, as an optometrist, it was actually my brother-in-law, an ENT, that identified that he probably had something going on with his eyes. So he was actually my first index patient. In the beginning, I didn't know I could help a dizzy patient, but it was after helping him that he connected the dots to my being able to help his dizzy patient. So it was an awakening for me. It goes back now almost 27 years doing this work. So to be able to help patients with nausea, imbalance with walking, and motion sickness it was really fun. And to this day, it's probably the highlight of everything that I do in helping this population.
It's so great because we know, if you study dizziness and imbalance, most of the people watching probably understand that it's not just our vestibular system that helps us with equilibrium, but it is our vision and our proprioception that helps us keep our equilibrium all the time. And so when the ear is not the problem and people still have trouble, sometimes seeing an ophthalmologist or optometrist is a good idea, don't you think?
Yeah, I would say the eyes, what we didn't really learn in school, but we're certainly learning now, is the eyes are playing a very important role in helping us know where we are in space. And when they're not working together as a team in an asynchronous manner, we can be quite uncomfortable. So our job during these neurovisual exams is identifying, are the eyes working as a team on the vertical horizontal plane? When we can actually measure that ever so slight misalignment, incorporating prism into the glasses resolves the symptoms, calms the nervous system, and improves gait.
Yes, so you're talking about two eyes working and moving together. I think that's the name of our talk tonight, binocular vision dysfunction. You're teaching us a new term. Is that what you're referring to? And can you explain what that is?
Sure, that's sort of like the global term for eyes that are in misalignment. It could be vertical, it could be horizontal, or both. So when that's not working, when they're not working as a team, that's when the system feels off. And usually people go right to the ENT, they go right to the neurologist, and they sometimes don't even realize it's their eyes. So for us, it's been an education to helping all of our colleagues know that this connection is a very important one, even just to peel off that visual layer from what might be an underlying inner ear, but to make them less symptomatic.
For sure. I think that you are going to help people realize that just like we talk about the inner ear systems being in balance and working in conjunction or in concert to give your brain a message that agrees, you're saying the same is true with the eyes, that the eyes also, that we have two of them, right and left, have to work together to give the brain a clear signal. So in some ways, those sensory systems, being that we have, that they're bilateral, they have to be in sync all the time.
Well, they do. And the vestibular ocular reflex is the connecting pathway. That's really the bridge between the two systems. And what we're finding is in the vision world, that's not really particularly appreciated. And in the dizzy world, it kind of is for the testing, but not that there's potentially a misalignment or that there's symptomatic relief. Everybody's kind of in their own silo on this. So
help people understand and remind us what the vestibular ocular reflex is. You're right. That's the neural connection that connects the two in the brain. So how does that work?
Well, let's pick apart the name, vestibular ocular reflex. So the vestibular system works in concert with your eyes to keep them focused on a target. This is particularly useful for when your head is moving. That way you never really lose track of what it is you're looking at. So this is helpful for walking, for running, any type of thing where you're moving your head, but you keep your eyes on the target. Your eyes
every
are
minute of your day, basically.
Pretty much every second of every minute of every day. So with that in mind, if you are out of sync with that, you're going to experience dizziness. So your two eyes need to work together as a team. Your vestibular system is what realigns or aligns those eyes to take into account the head movement.
That's interesting. So it's required that two things are working. For the vestibulo-ocular reflex to work and for us to have stable gaze, not only does the brain have to get the right message from the inner ear that matches, but the eyes have to be able to produce the reflexive eye movement accurately.
Correct.
Right? And does this have anything to do with visual acuity?
Well, certainly as each eye is identified individually as being able to see, we always knew that when two eyes are teaming, it enhances the clarity by 1.414. There's actually an enhancement when two eyes are in synchrony. So when they're aligned well, the clarity is enhanced and the nervous system calms, which I think is the most interesting thing. The anxiety that's often from being in a space that's unsettling to them can actually calm once we're actually able to align the images.
That's amazing. So what sort of symptoms do you see people come in with?
Dizziness, nausea, imbalance with walking, lightheadedness, nausea, and most of these symptoms, they have like more headache than dizzy or more dizzy than headache. They have, each one of them enters into it with a different level of severity in the category that bothers them the most. Some of them have been motion sick since they were young children, but it can get worse as they get older, or maybe they're fine as kids, but it gets worse again when they drive on faster roads. The highest Google search right now to our office is dizziness, and they don't even know it's dizziness. It's anxiety on fast roads.
Wow.
Just to take what Debbie was saying up to like the 30,000 foot level, the symptoms kind of fall into about 6 or 7 main categories. And depending on the categories, kind of like the way they go to get the treatment, to figure out what's wrong, to get figured out. But they frequently end up in an area that isn't accommodating for vision. So just as an example, pain, which was the headaches and the neck discomfort. They go that way to get help, but it's their vision. or the vestibular symptoms, which Debbie already covered, or the anxiety, agoraphobia, panic symptoms that end up in the psychiatric realm, or the reading and learning symptoms that end up frequently with vision therapists working with a vision therapeutic approach, but maybe not incorporating the prism, possibly. And then there's the standard vision symptoms. And then there's the traditional binocular vision symptoms, which is all people recognize as being associated with binocular vision dysfunction, which is double vision, blurred, shadowed vision, closing an eye to make it easier to read because you're getting doubled otherwise. And those are the only questions that get asked and understood to be visually mediated. The rest really get misunderstood and miscategorized, and unfortunately sends many of these people down the wrong path to get the help they need.
You bring up a
That's
very
amazing.
good point when it comes to all the different specialties that somebody can end up at. And I think this is one of the reasons why it's so important to have you guys to talk about this today. Because, you know, as a clinician, my eyes were opened after shadowing a vision therapist and who works with prisms and therapeutic approaches, where I realized there was so much more that I could do for my patients who had kind of reached their max on vestibular therapy, but still had these other symptoms that were more neurovisual related. So I think it's a fantastic point to make that all of these, everyone's different. They're going to have different symptoms, could end up different avenues, but clinicians themselves should really understand how to help their patient with a multidisciplinary approach, because it isn't just vestibular, it isn't just vision, it isn't just, you know, anxiety, pain, so on and so forth. It can be something that multiple people are needed to be brought in to help a patient feel less symptomatic. I will say you have a lot of fans in our comments in our chat who have been extremely helped by you guys and by prisms. So I have to say that, you know, a lot of people are in agreement with everything you have to say so far.
Cool.
I would agree with Danielle that the vestibular rehab professionals don't necessarily understand this. So I hope that we reach them with this message as well, not only for the patients who maybe have gone through traditional vestibular rehabilitation or medical management of their symptoms, but also those practitioners as well who need to know that if there's something else that needs to be done and hasn't been looked at, to go take a look at this. Let's talk about diagnosis. How, when someone comes in, you've given us some idea about what they come and they're complaining about and what their symptoms are, but what does the diagnosis of BVD look like? What does that entail?
So my favorite thing to be able to say to you is there are 25 questions that we've identified that comprise what I would describe as the most powerful tool in our toolbox. And that is called the bvdq, Binocular Vision Dysfunction Questionnaire. And what's beautiful about it is if somebody says, I think my aunt needs help, I think she's dizzy, she might need help, the most important thing I say is have them fill out the questionnaire and press send. And when and we'll give you the URL to use, isitmyeyes.com. When they fill out that questionnaire, it will actually be sent to a site where they can put down the state they live in. We have 30 trained doctors. So we can actually identify somebody who might be in Knoxville, Tennessee, for example. They might be in upstate New York. So the important thing is they fill it out, they press send, and up comes a score. And the way the score works is anything over 15 is significant for there being a likely vision piece to the puzzle. And then we can take off from there and look further into, you know, how severe is it? What do we need to do to get this person the help that they may need?
And I just want to piggyback on what she said. This questionnaire is something we developed starting back in 2000. And we always knew that this was going to be an important element of the work we did. So we worked diligently for years to get this thing scientifically validated. And it actually was validated last year and got published. So it's validated as a screening tool for this condition or conditions that are close to this. They require an evaluation by a neurovisual specialist regardless. So anybody who scores high on that tool really can benefit by a neurovisual evaluation.
I want to say that it's been validated in an neurotology journal. So
congratulations.
Thank you.
That is good. And yes, if you're one of those people who like to dive in and see the research, I think we have that link to where people can see that. If I know Cynthia will put it in the chat. So no, that's great. And it's important to us to have evidence-based resources. And certainly we're happy to hear what you're saying and then to hear the amount of work that you guys sort of pioneering this approach, the work you put into it to validate your tool. I think it's wonderful. Tools help us a lot now. So this is something that they can go online and they can take, and it's a series of questions. Is there a physical exam?
Oh, yes. We have an 80-minute neurovisual evaluation. And with that evaluation, we're observing gait, we're observing posture, we're actually doing provocative movements where we have them bend down, move their head side to side. We're actually looking at old-fashioned physical diagnosis. Along with the optics, of course, we're doing the assessment of what they need for an actual refraction. But then we take it all outside of the instrument and put everything into a test frame. And then we begin to work with that test frame in free space with prism to see how is their gait affected now? Can they now bend down and come up? So we can start sorting the elimination of those symptoms with the glasses.
And just to add on to that, we do before and after metrics. Because when somebody comes in and they don't feel good, you want to know how bad is bad. So we found 0 to 10 for the major symptoms. I'll try and get them all: headache, neck pain, dizziness, nausea, anxiety, gait instability, light sensitivity, and I think I'm missing one.
That's it.
Anyways, point is, we start with them on 0 to 10, and then we do our intervention, which is basically this diagnostic technique that Debbie mentioned, which is a custom fitting process for the microprism lenses. By the end of that process, there ought to be, on average, a 50% reduction in their 0 to 10 scores immediately. And that has to do with the way prism works and why people are having trouble in the first place.
I used to say the patients come in, their muscles are tight and compensated. Then we give that very first prescription and it relaxes the muscles. And then they wear those glasses for 4 weeks. Then they come back for a progress assessment and they're ready for the rest of the correction. So very often it's 2 visits. And at the end, we can find home for them where their system settles. We talk about a visual orthotic. So just like lifting a shoe to align my leg length, we actually call the glasses a visual orthotic to align the eyes, to synchronize, to view the world.
I love that term, visual orthotic. And so you are really talking about a special type of glasses, a lens, when you refer to microprism. And when you say test frame, you mean a frame of glasses, right? That you put in some sort of special glasses. So what does the prism do? What is a microprism lens exactly?
So prism bends light. So if I'm measured to be off alignment, let's say on the vertical plane, if I apply prism, I can actually align the images as the lens bends the light. I might be off horizontally. And again, we can use a lens, it'll bend the light to synchronize those 2 images. Sometimes the patients will say, you gave me one eye. I never had one eye. I always had 2 that didn't work together. And like a cyclops, they sort of joke around and say, I feel like I'm now synchronized. So prism will bend the light to synchronize the images.
And just to piggyback on that, the reason that's important is that these people are struggling like crazy not to see double. So there's this terminology, it's called heterophoria, and it can be on the horizontal or vertical plane. But what that is hetero means different, and phoria means lines of sight. So the lines of sight for these people are different, but their visual system is able to try and fuse the image. Okay, that should be an easy thing to do, but in this patient population, it is not. So they spend all day long struggling and fighting to get those images to get together, and all those symptoms come from this overuse of their system. The eye muscles get fatigued and tired, they hurt. That's the headaches. There's movement back and forth of the eyes going in and out of alignment. This is without prism, the natural disease state. Some folks describe that as a vibration in their vision or shimmering. Well, that's their eyes moving and their brain doesn't think, or the vestibular system doesn't think they're moving at all. That's dizziness and all the rest of the vestibular symptoms. The misalignment for us tends to be vertical, which means if one image is higher than the other, you can actually do something really simple. You can tilt your head. So it's really not uncommon as you do your physical analysis of your patients. Don't be sitting on the side. You got to be planted directly in front of them and see what their body posture is. And if they're doing one of these deals, and if their hair happens to be parted on the high side, I don't have any hair to part anymore, but back in the day, it's a confirmatory thing that they've got a posture correction for the misalignment. So all the symptoms come from the misalignment. The prism doesn't really change the misalignment of the eyes, but it moves the image. So now there's no longer the struggle. There's an issue with, we can get into this later if you want, with bad signaling causing the misalignment in the first place. But this allows the vision to correct and the fight and the struggle stops, so the symptoms get better. That's how the microprism works.
That is beautifully said. And I think in the vestibular community, we recognize that because we talk so much about the fatigue because of the effort that the brain is involved in just to try to make things right, just to feel steady, to feel centered and grounded. It's exhausting. So if that's happening the same time now because the eyes aren't exactly right, I'm sure the eye muscles are trying to correct, the brain is trying to fuse the image, and again, another exhausting feat for the body and the nervous system just to try to feel steady. I think that those who in the vestibular community who struggle, it's one of their biggest struggles is these nervous system symptoms, this feeling of my body is trying so hard to do some correction and it's not able to. And it is those symptoms, whether it be muscle tension, headache, neck ache, postural dysfunction, besides the real primary symptoms of instability, balance problems, visual problems, they have all these secondary things. And I think those are sometimes more burdensome than the primary symptoms. Yeah, you talked about that. We have a great
question from the chat. Oh, sorry. I was going to say we had a question actually pop up from the chat that kind of relates to prisms and our binocular visual dysfunction. But are prisms always appropriate for BVD, or are there times where maybe the prisms aren't recommended?
In the end, we don't really know until we evaluate the patient. I say that everybody's a snowflake. We don't really know until they arrive in our office. I do know that if they fill out the questionnaire and their score is high, there's likely to be a vision piece to the puzzle. So I'm a big referrer. Next to my prisms, I love my referral drawer. So if I need to send them out for that next level of care, I like to get them where they need to go to get, let's say, the rest of the way better.
If there are people in the audience who are wondering.
Everybody is individual. Go ahead, Kathleen.
Sorry, Danielle. I'm sorry. I was going to say, I love that. If there are people in the audience who want to say, I wonder if this is for me, is there a quick test? I think you gave me a video of a quick test that people can try. And I like it because it really helps us appreciate this. Can we take a look at that? Tell us what we're going to be seeing here.
So this is called the 5-minute cover test. We know that the questionnaire works and is validated, but that tells me as a clinician, you're a candidate. The 5-minute cover test tells you because your symptoms will actually dissipate in the middle of the test. You'll find relief after doing it.
So we're not going to hold for 5 minutes, but I do have a clip of you instructing people on how to do it. Go ahead, Dr. Mark, and then I'll show the video when you're ready. What were you going to say?
Well, what Debbie said goes right into the physiology, which is they're struggling to maintain a binocular image and they're symptomatic. So if you can break that desire to be binocular, their symptoms should get better. When we treat them with prism, their alignment gets better, so there's no longer an issue. But as you cover one eye, you've now broken the chain. So they're now seeing singularly or monocularly. There's no drive for that binocular fusion. The symptoms should get better. That's why the test works.
So let's take a look at this 5-minute cover test.
I'd like to teach all of you how to do the 5-minute cover test that will help reveal whether or not you have vision misalignment or a two-eyed problem. The test is called the 5-minute cover test. First, you identify what are your symptoms: headaches, dizziness, nausea, anxiety. On a scale of 0 to 10, identify what is your number at that moment. Let's say you have dizziness and nausea on 5 out of 10. So you first identify which is the side that you go to more comfortably. So as you can see, I go to a little further to my right shoulder than I can even go to my left. So my high eye is my left eye. Whether you wear glasses or not, you take your left hand in this case, cover your left eye, set your timer for 5 minutes. Look at a blank wall about 8 feet away and just relax. At the end of the 5 minutes, when your timer goes off, reassess your dizziness in this case, or your nausea. What's your new number after 5 minutes? Those numbers should go down by 1/3 to 1/2 in 5 minutes if your eyes are involved. Once you remove your hand from your eye, you may feel a little bit off or a little bit uncomfortable. That's another confirming piece that this was a two-eyed problem.
That's helpful. I think a lot of people will be trying that at home. And is that a good screening tool for vestibular rehab therapists to use as well, along with the questionnaire, to see if they might need to go find a neurovisual therapist or neurovisual doctor?
It certainly could be added to the bvdq, but there is one caveat. If someone hasn't been seen for an eye exam in a very long time, and they look with each eye separately, and they're not either of them seeing clearly, or one is not clear, that test will not work as well. So the caveat is we have to at least have pretty decent vision before we start to cover an eye.
That's a good point. And I think most of our patients, when I evaluate patients, I do ask about when the last time they had an eye exam was, and do their glasses work for them? Sometimes that's my way of saying, do your glasses work for you? People know whether their glasses work for them or not. And so then you're assuming that they have their refraction tested, but not necessarily this particular thing. Are there certain causes of BVD? I was wondering if, I learned in school that if things were congenital, a lot of times the body can adapt to something that's a small shift or abnormality. Are these congenital or acquired, a mix of both? Do we know what could cause it?
Definitely a mix of both. And the congenital variety can be the motion sick child, the struggling reader as a young child. And then the more birthdays they celebrate, the less they can compensate. So many of these patients hit their 40s and they go, something is not right. And so those are the patients that are more congenital. Then there are the TBIs, traumatic brain injured or acquired brain injury patients, where after, let's say, a head injury in a sport, soccer, lacrosse, stick to the head, or simply somebody falling on black ice or a motor vehicle accident, those patients tip over with all the panoply of symptoms. So they're probably the very most symptomatic, but they're also the most receptive to correction. Their system cannot compensate. So the minute we start to introduce alignment, it's just this flood and wave of calm in their body as the images, there's no more fight left. They can just relax and see for the first time since their injury.
Now, this is a question from the comments, but can VVD be transient? Can this be something that kind of comes in and comes out?
Yes, especially my 40-something patients. So they have a good day and they're full of energy and they can focus all day long in that screen. And then the next day they sort of collapse because they did 10 hours of screen work, or maybe on the weekend they feel pretty good and then they go back to work and there they are staring at a computer again. So the more driven we are to do intensive close-up work, the more people can tip into that symptomology. But yes, it can be transient when they're just starting to lose that ability to compensate.
What else from the comments, Danny?
So I'm taking a look here. Let's see. So are there other conditions like vestibular migraine or other things like that can make that transient? I know we can have visual deficits or visual changes with migraine. That could be something that potentially causes that transient BVD. Is that correct?
We like to sort our migraineurs. It's really important to sort them to see, are there any foods, for example, or environmental triggers that make you feel worse? And I had one woman who I helped her 50% with her headaches. Then she said, but what about those other headaches? And I pulled out my MAV questionnaire. What happens if you eat chocolate? What happens if you drink red wine? And those are simple ones. But as we go through this questionnaire, she lit them all up. Then she went on the diet, Heal Your Headache, and stopped some of those foods. And she felt like the rest of the headaches went away. So I always say it's always multifactorial.
Yes.
We certainly want to sort them fully to help them the rest of the way.
And
So
just
in those cases, are prisms helpful? Are they still indicated when things are kind of coming in or out? Or is it maybe something that's worth trying out and testing while going through the diagnosis?
Certainly, you want to peel off that visual layer, and you will not know that it's even there unless you evaluate it. So, there's a woman, great story. She comes in, we're testing her, we're trying to give her prism, sort of borderline responsive, but still has all these symptoms. A unique story. She had a tooth that was infected, and she had a root canal, so she couldn't feel the pain in the tooth. Finally, they took that molar out, and all her dizziness went away. So I'm a big believer in digging deep and looking at and listening to the story. What is the patient telling us? Where did they enter into their symptoms? So just keep peeling off those layers, but let's make sure the vision one is addressed.
And Danny, I just want to answer this a little bit differently. If somebody's going in and out of symptoms, they need help. What it is they're right at the edge. And some days they're on this side of the edge, and on other days they've fallen off the edge. So if they're intermittent, what you're really hearing is somebody who's gotten to the end of the road, and treatment is actually indicated for those people. And then just to add real quickly to one more thing Debbie was talking about a moment ago, we see people, there's an overlap of symptoms with a couple of other conditions that end up finding their way to us. So MAV, migraine-associated vertigo vestibular migraine, is one of those subsets where the symptoms overlap. So if there is a visual component, we can help, but sometimes they also need treatment for that. Same thing true with dysautonomia or postural orthostatic tachycardia syndrome, or POTS, if you're familiar with that condition. There's a lot of symptomatic overlap. And then there's two other ones, sound sensitivity or hyperacusis, as well as something called SSCD, or superior semicircular canal dehiscence. And they frequently all have a visual component, but they frequently all we're not the last stop for them. They're going to have to go on to get further treatment.
You bring up such a good point. And I was thinking to those who are still looking for their complete recovery, it's not finding which box you fit in, it's finding all the boxes and putting a little piece of you into each one, because it is often multifactorial, and we can't separate the impact that the vestibular system has on eye movement coordination because of that reflex you spoke about. So there are some overlaps, and I know in vestibular disorders, they when one side it has hypofunction, can be an ocular tilt, a turning, a twisting, an imbalance in the eye position, and then the rest happens. So we can't separate that out. Oh, go ahead.
There are a couple of questions that people are asking in the comment section about, should I wear my glasses for the test or not? And the answer is, if you need your glasses to see at 8-foot distance, it may not have been in the video, but you should be sitting in a comfortable chair an 8-foot distance away. So if you need your glasses to see at that distance, even if they're bifocals, you should have them on before you do your test.
Good. So you want the maximum acuity adapted even that you can during that test. Well, that brings me to that. So we have a video of someone who, a client of yours, an actual client of yours, who comes in with symptoms, and then you evaluate and treat, and then we get to see the outcome. Do you recall the video I'm going to show, and does it require any setup? Tell us what we're going to see here.
Just that this is a young girl who came to us after an automobile accident with all the classic symptoms we've been describing. This is her same day pre and post.
Same day pre and post. Here we go.
And then come on back. What happened?
And I started to feel unstable and go to the right, and then I started to correct myself, and I still kept on pulling myself to the right.
come on back. Stopping right there, what did you notice?
I don't go to one side and I feel stable when walking. I don't feel any kind of dizziness or I don't feel like I'm listing to one side or another or trying to compensate when I'm walking, and I'm able to walk faster.
That's so cool
That's
to see.
wonderful, isn't it?
So when we took the fight away, her system could relax and be grounded. And so that was just that constant effort of synchronizing the images.
It's amazing because as a physical therapist, I look at that and I see all the differences in changing from her gait speed to her stride length to her base of support to her arm swing to her drifting to the right and left. I mean, multiple aspects of her walking pattern, of her gait were impacted by normalizing the vision. Good job. That's great. And there are a lot more of those video testimonies on your website. I've seen them. So it's not just one. It seems to be, you're saying that that's a regular occurrence, that you can see some pretty instant response.
Yes, we know we can help them the day of the visit. So that's why I always say, if you score high in the questionnaire, you really need to be able to be evaluated so that you know that this can be an idea that could help you or a treatment that could help you. Even if it peels off half of the layers, it lets you help find the rest of what's going on.
So I'm going to make an appeal here at this point in time for the clinicians that are watching, that if you are having a patient that isn't progressing as you would wish, they're not getting as much better as you would hope they would have, or they're not improving at all, or they're stuck in their therapy, and you've done your wonderful usual magic, and this is where they're at, consider this as a possibility. Doing the questionnaire is pretty quick and easy. The 5-minute cover test is pretty quick and easy. And it's definitely something that we found impedes progress in these various therapies. We've talked with our local vestibular therapists, and they will tell us that prior to this patient coming to us, they had plateaued. They'd done well, but they got stuck. Mm-hmm. And once we were able to help their binocular visions issue, they just took off like a rocket because they were like anchored, if you will, because of this. So it's definitely something I want people to consider when they've reached whatever seems their limit. Yeah,
it makes perfect sense. This is something that I had noticed in my practice with working with vestibular patients who were plateauing or even post-concussion patients. And it seems like we couldn't get over that final hump. And it wasn't until I explored and started to follow some of these neuro specialists or the neurovision specialists, that it started to make sense to me that if half of your VOR system isn't working correctly, then how the heck can we repair it? So having somebody like you to refer their patients to help them with that multidisciplinary approach is going to be a huge help to their patient. And it's also just going to make sure that they continue to progress forward in their treatment. There was a question in the chat that I do want to ask, because I'm also curious, but have you seen any sort of increase in VvD since the rise of COVID?
Oh, yes.
Can you repeat that question? I didn't hear you very well, Danielle. Go ahead and repeat the question, Debbie.
So somebody had asked a little bit earlier in the chat, and I'm curious because, we've seen a little bit of a rise, or I feel like I've seen a rise in vestibular dysfunction since COVID started, but have you guys also seen a rise in BVD since COVID has been kind of taken hold?
So there's two phases to that question that I think of. The first is, COVID means we're in a pandemic and everybody's sort of stuck at home, and kids are stuck on screens and parents are stuck on screens, and all that visual demand is tipping people over. So I would say most of my colleagues have said they've seen this huge influx of people with symptoms that are driven by eyes that don't work together, and they start getting all these symptoms. So that's what I think you're asking. Is that correct?
That's one answer.
And then the other category is a sadder part of the story, and those that get COVID and the long haulers. And those are my heartbreaking situations. I've had 2 patients with actually dysautonomia or POTS post-COVID. They're struggling, and that's a perfect example of where I will send them out to a POTS specialist or a dysautonomia specialist. I'll try as I can. Occasionally I can help them with support visually, but very often they need a lot more part of their system addressed with a specialist.
That's a great answer. And I think that's true for so many of us. We're seeing post-COVID morbidity that have to do with the change in lifestyle during a pandemic, and then others that are a direct result of introduction of the variant, the vaccine or the virus, one or the other. We're seeing a lot of new things. So we don't know all the answers. We're still writing the story, aren't we? I really like the way that you guys do the evaluations, the way you listen to people. You clearly have a heart and compassion for this work, and appreciate the multidisciplinary approach that is necessary. That comes through in your interview today, just how much you care about these people and how you are doing such a good service to them. And so you're training other physicians to do this. How would someone find help if they did the questionnaire and maybe you weren't in your area? How do you find help?
So the best way to do it is to fill out the questionnaire, because the way we've set it up is if you go to isitmyeyes.com, you will be led to a 25 question questionnaire, and you fill it out. When you press send, that will then, by the way, as you're filling it out, you're also asked, what area do you live in? And you'll be able to, that questionnaire will then get sent to one of our 30 colleagues that we personally trained around the country. So the goal is to get you to somebody who actually knows the way this protocol unfolds and to be able to help them. So that's the important part, is filling out the questionnaire, and then it will go, you'll pick your area, it'll go to a colleague, and then they will receive a call or an email or a text back, and they can begin a dialogue back and forth.
And I just want to toss onto that we have personally trained these people. There's only 30 of them around the country. Now, there are other doctors that do work with prism, that work with vision therapy. They have other approaches, and they are effective in some of this patient population. But what we do is very specific. Dr. Debbie's technique using the microprisms and that assessment, she developed, and the people that we've trained use that technique.
One of the questions on your site talked about how the doctor noticed that they weren't using their right eye very well, or it sort of was not participating, if you will. We call that suppression. If this eye is not working very well, or if it is, I'll see double. The brain sort of finds a way to suppress the image. Those are candidates for care. So when you take that eye that's just not letting you see double, because the brain hates double vision, when we use prism in those patients, that eye sort of wakes up and it can participate. So that may be an entry point to needing care. Another one of your questions talked about how does sound affect vision? And we all learned a little bit in school about Tullio's phenomena. Tullio was the scientist who harmed the inner ear of the pigeons, and then the pigeons couldn't walk a straight line and their eyes quivered with nystagmus. So that's a whole nother topic, and that was all happening from sound. So we know that sound can move the eyes thanks to Tullio, and that requires a deeper dive with potentially an otologist or a neurotologist or an ENT. So I just wanted to answer that little question that came through.
Very, very good. When you talked about using the microprism for people, is that curing something or adapting to something? And what my question is it permanent prosthesis or orthotic, as you called it, or temporary?
Most of our patients seem to respond to needing it year after year. And if they're already eyeglass wearers, we're just putting it into their glasses. So it doesn't change their lifestyle very much. There are those who occasionally do not need it over time. Those are the ones that might be an early treatment. And then as their trauma heals, then we sometimes find they don't need the prism.
Very good. Let's see. You're doing such a good job on looking at the comments yourself. Let's see what else is here. We lost Danielle. So
there was a question about PpPD.
Oh, good. Oh,
And
I know, and I have
just-
another question too. Go
I
ahead.
would just say that in general, it's referring to the emotional state that we can be in when we feel unsafe or uncomfortable with our condition. So many of my patients have been told maybe they have a mental health issue when in fact it might have been their eyes. So I think it's one of those visits that's important to just peel off that layer where the anxiety is coming from feeling unsafe in space. And once that's resolved, some of that anxiety really does calm. So they could be reevaluated. Do they really have an emotional state that needs medication?
I agree with you that those with PpPD or triple PD need to continue to turn rocks over and look for things that can help them. I could imagine that there would be those with that diagnosis that have that nervous system anxious state of unrest that could benefit from taking a look at their eyes together. How does this differ from oscillopsia? We use the term oscillopsia to understand the symptom of how things look when a person has an abnormal vestibulo-ocular reflex and the way things look, a jumpy vision, or that you're holding a camera and walking through, that things look jumpy. How does this differ? Could you distinguish between the two if you had them?
Yeah.
Go ahead.
I would think that what we're describing with the symptoms of vertical heterophoria are a more subtle version of oscillopsia. So if things got worse, you would have more movement. That would be this oscillopsic picture, like when you're walking and things seem like they're bouncing up and down. As it is with our patients, some of them will tell us that they do see vibrations, shimmering, movement. And I think it's in the same category, but not as large or as gross as an oscillopsic picture.
I think the term is difficult to answer one question with one term because what word we use to describe movement and bouncing can be different for each person. There could be an earpiece to that puzzle. There could be an eyepiece. There could be a neurological piece that I can't touch. So I think it deserves an evaluation and a sorting to see if they are going to be responsive to correction.
I'm looking at the questions here, and there's
Hold on, I wanted to add to that real quick. What you just said, Dr. Debbie, is so important because people often, I see in these chats and these comments, because we do so many of these, they'll say, I have this. I was told I had this. I have this. And you get stuck to a word. And I think what you're alluding to is the fact that when you continue to look for help and look for hope, you have to keep looking. And sometimes it means you have to set aside the word or the name of the problem that you were given, because you could be missing something by sticking to a particular word like oscillopsia when in fact it could be this. And I think that's true a lot with this group of people, that there can be some confusion about words given and diagnosis given that may turn out to be inaccurate. And that's why they're not getting better. So go ahead.
One of the comments was talking about Maildy-Debarkman syndrome. I just wanted to toss in that we're actually doing some research into that right now, and there does seem to be a correlation between binocular vision dysfunction and Maildy-Debarkman. And I would encourage people that have that diagnosis, and if they're not getting better with their current treatments, to try taking the questionnaire and let's see what the score is. Also the 5-minute cover test. That would be a completely different approach, and it may well be what is going on.
I've had patients that say, I was on the boat, I got off the boat, I still feel like I'm on the boat. And I've been able to help a number of those patients. They had this misalignment that they sort of managed. And when my brother-in-law, Mark's brother, the ENT, helped me learn about the ears, he said the eyes, the ears, and the proprioception are what help us with our GPS knowing how our body is balanced in space. So if you think of going on a boat, we don't have the ground underneath our feet anymore. And then if our eyes aren't right, now we have 2 out of 3 systems knocked off. So just by stabilizing the vision, sometimes people with Maildy-Debarkman can feel more grounded with correction.
Well, I just saw Danielle flip a whole 360 on here, so I'm having some visual problems with this. with this video. So for those of you who think you're having an episode, we did that on purpose to make sure.
Sorry about that.
That's okay. Glad you're back. This has been so comprehensive. Danny, if you get a chance to take a look, and you were looking at the comments too, see if we got everybody. But I'll tell you, we just appreciate everybody coming in and being so participatory. This was a great session, and we'll continue to watch the comments on the Facebook page. If you have additional questions, feel free to continue to chat about them, and I know that we'll be watching and trying to direct you. This was just very, very terrific. I think you covered everything I could have asked for, with good evidence and good information and real practical knowledge for people to have. So that's all I have. What about you? Is there anything else you wanted to make sure we knew and understood before we go?
I always like for patients to know there's hope and help for them. I think it's so important. And science doesn't stand still. We are always learning. There's always something around the corner that can teach us more. So I would say always remain hopeful and keep looking. And I think VeDA does an amazing job as a Wikipedia resource for all these different conditions that can cause people to not feel well and to feel dizzy. So I just thank you for this opportunity to share our work and become one of the members that helps others.
And the only thing I want to add is the website that we have right now, vision-specialist.com, is rather encyclopedic. I've been told by a number of marketing experts that this really doesn't look that good for marketing purposes, but it's got a lot of information. So, if somebody's with VeDA, somebody's having significant dizziness issues, as a rule, they tend to be really good researchers because, you got to look for yourself. That is a resource that I think might be of some use. So I just want to encourage folks to look there for that.
And a lot of
well,
times,
guess what? We get that same comment about our website too. It's because we have so much to say, and we just love talking about our work so much. It's very encyclopedic, and they say too many words, too many things. But
well, I
there's
also
a
like
lot
to say
there.
that many times my patients really can't read because they don't feel good when they read. So they often will say, "We found your YouTube channel, Vision Specialist of Michigan," and by looking at those videos, they can begin to recognize themselves in the stories that the patients share. So that's another way to help them feel like there's somebody that reminds them of themselves.
And we feel really lucky. We've been doing this for 25 years now, and we're 15,000 patients down the road, and we're doing research. And, it's just really cool to be able to do this. My background's emergency medicine is what I used to do up until just a few years ago. And that was nice because I was able to help people a lot. But I used to tell Debbie I was pretty jealous because I didn't usually have every new patient come in and get 50% better. They just didn't, and she does. So it's really a great opportunity to help folks a lot. And they usually have been suffering, and they usually been around the block, like 10 times. And they've seen everybody, and they've tried everything. And then they come in here, and there's a lot of tears, and it's a lot of happiness. And we're able to make a big impact for a lot of people. This isn't for everybody, We have a hammer, not everything's a nail, but the questionnaire and the 5-minute cover test starts the sorting process on who we probably can help. And if somebody, like I said, hasn't been achieving the kind of resolution they're looking for, they should investigate at least the simple tools, the questionnaire and the 5-minute cover test.
I love it.
The time that you gave us today, just because I know I've garnered a lot of information that I'm going to take back to the clinic and use with my patients, just because there aren't a lot of people out there like you guys. And we're very grateful that you're training other clinicians and individuals to do what you do, especially so thoroughly and holistically. I love that you guys look at gait and function and how somebody has to move throughout their day. So this is just absolutely amazing. I do want to encourage everyone to look at your YouTube, to go to your website, even clinicians to use that encyclopedic website to kind of help educate yourself and get information to your patients, which can be of a great help. So we really, really appreciate your time today. These live interviews that we've been doing with VeDA now once a month have just been, I think, absolutely amazing for all of our community, whether there's somebody suffering from dysfunction or a caregiver or a loved one of somebody who's suffering. And the information that you guys provided today was just top notch. Thank you so, so much. We really appreciate it.
Thank you.
Thank you for the opportunity.
Thank you. We'll see you all next month. Go to vestibular.org for more videos like this one. Also there, you'll find information, support, and encouragement to help you find your journey back to balance.